Hello, my name is Gerry Hanna, and I'm here to chat to you about lung cancer radiotherapy. It's my distinct pleasure to be invited to give this talk at our OncoAlert Colloquium this year. These are my disclosures, none of which are relevant for today's presentation. Now, I want to talk about four general themes that are pertinent relevant to radiation oncology, and these do include timing of drugs on radiotherapy, that's with immunotherapy in mind in particular, thinking about de-escalation and becoming more immune aware, and also thinking about regime compression, I shorten it, but making it more hypofractionated, and how we do this without losing efficacy. And also, I want to mention organ sparing techniques, and specifically around that, large data sets and learning systems that have been set up to do this. And we're really looking for signals across meetings and across journals. By putting this together, I selected those abstracts that were presented at what are the key really radiation oncology conferences. That's ASTRO, ESTRO, also the World Congress on Lung Cancer in 2025. We also selected some papers that were published in our leading radiotherapy journals. And we had a preference for those that were prospective, that were randomized, that give us some real world signals that would be useful to inform our radiation oncology practice. And we were also interested in those that had endpoints that were hard, such as OS, PSF, and also those that give clear toxicity readouts from that. And although this is not a comprehensive systematic review, it is hopefully a curated highlights of what is relevant to lung cancer radiotherapy from 2025. So kicking this off, we're straight into stage one and operable stage one non-small cell lung cancer. And this is the revised STARS study. This looked at patients who had operable stage one non-small cell lung cancer, less than 3 centimeters. We sometimes now treat a lot bigger, up to 5 centimeters routinely. And I would even go a little bigger if the lung dose constraints permitted. And this enrolled 80 patients who were propensity matched to a separate group of 80 patients who were having a VATS lobectomy. And the 80 patients, SABR, who had baseline staging with an EBUS, but only 25% of those going to surgery had a preoperative EBUS. The primary endpoint here is overall survival, and there was a median follow-up of 8.3 years, and they did look at 10-year quality. If you look to the right of your screen, you can clearly see that there is really no significant numerical difference between OSF or cause-specific survival. The only difference is in moderate to severe acute complications, which is, as we would expect, higher with surgery and not really measurable in the patients who received stereotactic ablative radiotherapy. So this does give us reassurance that for those patients who are borderline operable, that we should really have the conversation about stereotactic radiotherapy with them, as well as the conversation about surgery, and allow patients through shared decision making to make up their own minds as to what they want to go to. And this also points to that there is really equipoise in this group, and that we really need to recruit to the ongoing phase 3 study. And a big shout out to both the VALOR study led by Drew Mahaganaki and also the Stablemate study. And these results are really eagerly awaited in terms of which patients will benefit most from SABR and those which will benefit from surgery in stage 1 non-small cell lung cancer. Staying with early stage lung lesions, and although this is not technically non-small cell, I want to include it because it's quite an interesting technical radiotherapy study of MR-guided radiotherapy in patients with lung oligometastases. This study, which is one of the first prospective studies, cohorts looking at patients who had small lung lesions, some 26 patients with 30 lung lesions, and they were treated with MR-guided stereotactic radiotherapy. This used all the technology available, including tumor tracking during treatment, obviously gating, and by doing that, they were very certain with a high degree of probability of where the tumor was, and therefore they reduced the margins that we put around the tumor as we see it on imaging, and reduce those margins to hopefully improve the safety of radiotherapy. Even though SABR is safe, we're constantly trying to improve that safety. Now, in this study, the local control was 96% at 1 year. That's very high, as we would expect with SABR, 77.5%, nearly 80% at 2 years, again, as we would expect. And very importantly, there were no adverse events that were grade 3 or further, reinforcing the absolute safety of stereotactic radiotherapy in this cohort of patients. This is really interesting because this reassures that MR-guided radiotherapy appears to be safe for these small lung lesions and is worthy of further investigation in prospective further studies. And it'll be interesting to see how it's used. It is obviously a very technologically demanding treatment and not available universally at present. Now, on to stage 3 non-small cell lung cancer, and this is the EA 5181 study, and this was presented at the World Congress in Lung Cancer in Barcelona in September. And this was a randomized phase 3 study that enrolled 662 patients who had unresectable stage 3A to stage 3C non-small cell lung cancer, and also included patients who had the same staging but who had mediastinal nodal recurrence after treatment for early stage disease. And patients were randomized to receive either concurrent chemoradiotherapy and concurrent durvalumab, followed by adjuvant durvalumab, for a year, and they were randomized to either to chemoradiotherapy alone with adjuvant durvalumab for a year. So basically, the experimental treatment is giving the concurrent durvalumab. As you will see in the bar charts on the right of the screen, there's no numerical difference and no statistical difference between median overall survival or median progression-free survival between the two patient cohorts. And this again reinforces that post-chemoradiotherapy, durvalumab or adjuvant durvalumab is still our standard of care. And it looks like concurrent is really not a strategy we're going to pursue at the moment unless we've got good biomarkers that may inform the patients who did better with that strategy. This is entirely expected, of course, and we remember the results of the Pacific study, and you see the plots there as presented by Geoffrey Bradley at the European Congress in Lung Cancer in Prague in 2024, the year before. So no role for concurrent durvalumab just at present. This is an interesting study looking at dose painting and using a PET-CT to dose paint or reduce the dose to less at-risk areas inside the mediastinum. This is looking at patients who generally had no positive disease, and patients were enrolled to receive as a control group a standard 60 Gray and 30 fractions to the primary involved nodes with concurrent chemotherapy. And the experimental arm was giving a hyperfractionated dose of 55 Gray and 20 fractions as the key backbone, again, concurrent with chemotherapy and whatever adjuvant therapy would have been standard. Patients who had a PET signal that permitted dose de-escalation in the nodal areas had their dose reduced to 44 to 48 Gray in the non-at-risk areas. And what the study was looking for was really the safety of this approach. Did this lead to increased relapses? And this is a concern if you're dose de-escalating in non-small cell lung cancer. It's not a disease where we do so well that we have the luxury of de-escalation of therapy. But what we're thinking of here is trying to avoid immune toxicity and toxicity to other organs at risk when we're doing radiotherapy. This study, thankfully, has shown no difference in both progression-free survival and overall survival in either group, and this is reassuring. They did note that there was a reduction in what we describe as an immune-relevant toxicity, that of grade 3 or grade 4 lymphopenia, and the dose painted arm had a much reduced rate or instance of lymphopenia during treatment. This gives a little bit of reassurance that we may be able to dose escalate to less at-risk nodal stations in patients. It also points that where we are more targeted with our radiotherapy, that we do preserve the immune system. This is probably very important as we look to further combine immunotherapy with standard approaches in non-small cell lung cancer. Keeping with that theme of dose de-escalation, this is looking at the rapid RT study from the Christie Hospital group. This is a very large cohort study, and this enrolls patients from stage 1 to stage 3 non-small cell lung cancer. And it looks at assigning quite stringent dose constraints and then modifying those dose constraints as the model learns. And what this is particularly looking at is the mean heart dose, and again, trying to, again, model that in a way that we minimize the dose to the heart. They are also looking at another question: can they again reduce the dose to immune cells? That's not the key purpose of what we're going to describe here. But in some work presented at ESTRO in Vienna in 2025 by Gareth Price, they showed that that first of all that they were able to get at least half the patients, or up to half the patients with the enhanced constraint. And when they did that, they noticed that there was a modest improvement in 12-month survival, and more follow-up was ongoing. So this is very encouraging to suggest that when we really technologically optimize our radiotherapy, that we do see an improvement in survival by enhancing our safety to our organs at risk. Switching gears now to limited stage small cell lung cancer. This is a study that randomized patients who had early stage disease who were due to receive concurrent chemoradiation. It randomized them to a standard conventional radiotherapy fractionation of 60 Gray in 30 fractions over 6 weeks, 2 Gray per fraction. And it compared that to 45 Gray in 15 fractions over 3 weeks. That's giving 3 Gray per fraction. And again, it looked at survival endpoints. Now, this study did not meet its primary non-inferiority threshold in terms of overall survival. So in theory, it is a negative study, but it did, however, if you look at the overall survival curve, there really is not a lot of difference between those two curves. This suggests that hyperfractionation may be nearly or certainly as efficacious as conventional radiotherapy, and is worth considering and taking further forward. What they did report, and this is quite interesting and enticing, is the fact that there were reduced grade 3 adverse events or greater, and there was a reduced rate of lymphopenia in the patients who had the hypofractionated regime. And this is definitely where the investigation in terms of optimizing patients through treatment, particularly in the immunotherapy era. A slightly different strategy is currently ongoing. This is the NEEL study from our Norwegian colleagues, and this is looking at dose escalation now. This is not dose de-escalation. And they are looking to see, can they give a dose of 60 Gray and 40 fractions? If that's not possible, they will get a standard Chirizi regime of 45 Gray and 30 fractions concurrent. But if they are able to receive the 60 and 40, they are randomized to a dose escalation to a dose of 80 Gray and 40 fractions. That's really quite hot, or a standard dose of 60 Gray and 40 fractions. And we look forward to seeing this. Of course, on the right of the screen, you can see they're very clearly being very specific and strict with the normal tissue dose constraints. So in our cross-cutting themes, one theme is really emerging. You can see this from all the studies, is immune-preserving radiotherapy. The repaint study, the limited stage early small cell lung cancer studies, and a lot of other analysis are really can see how do we preserve the immune system, what is the effect of doing that, and does this improve outcomes for patients who receive immunotherapy in whatever format. And we look forward to see how that takes us. So in summing up, what is practice changing? Well, I think that what's very clear is that the EA 5181 study does not support concurrent durvalumab, but does support, again, adjuvant durvalumab. Okay. The STAR study does suggest we have equipoise between SABR and surgery in borderline operable stage 1 disease, and we wait the other studies. And we are looking at, PET-guided and other imaging techniques to de-escalate, to tighten our treatment fields. And we're also looking at hypofractionation to help us with immune preservation. And I think we'll see more of those strategies going forward. And I think one operation is the value of big learning systems such as Rapid RT. They are really the way we're going to answer very complicated questions in complex patient cohorts. Looking forward, we will see hopefully that comes for Raptor, consolidated radiotherapy in extensive stage small cell. We'll hear more from Rapid RT. We also look forward to a very novel study, the Conquer study, looking at DNA damage repair inhibitors alongside radiotherapy in stage 3 and stage 2 non-small cell. Biomarkers will be important, and the increased role of SABR and oligometastatic non-small cell with the results hopefully of the SARAN and HALT studies hopefully later this year will hopefully inform what we do. Very finally, can I thank you for your attention?